And now we will finish discussing the development of the face by talking about the nose and the mouth. Okay, so the nasal and oral cavities, which really just means the space within your nose and the space within your mouth. Okay, so how do we do this? Starting in week 6, remember the nasal pits? Okay, well, they're going to continue to get deeper as that frontonasal prominence is growing outward. So the nasal pits are growing inward and the frontonasal prominence is growing outward, and that makes for deeper pits. Now, when the medial nasal processes, when they merge, and we talked about that in the last lecture, okay, and those are the red arrows in the top picture. When they merge, they actually bring the back ends of the nasal pits together, and that forms the nasal sac. So now the nasal pits are continuous with one another, and that creates this empty space called the nasal sac. And I should say, when you're looking at these pictures, for this slide and the next one, the second and third pictures are showing the embryo in profile. So the first one you're looking at it head on, the second one it's in profile, with sort of the front of the face to the left and the back leading back into the head to the right, although that part's not shown. Okay, so the nasal sac that we've just made, the floor of the sac and the posterior wall, so the back wall, are going to thicken. And it's going to grow, and that will separate the nasal sac from the oral cavity, okay? So the future nose space from the future mouth space. And that structure that's formed is called the nasal fin. That's what's shown in purple there. Okay, on to week 7. So again, same idea here. The first picture is looking at the embryo head on, and the second is a profile shot, okay? So within the nasal fin, you get the development of these fluid-filled spaces that they're called vacuoles, which isn't specific to this particular portion of development. A vacuole is a fluid-filled space no matter where it is. But they develop, they merge with each other, and then they merge with the nasal sac, which has 2 effects. One, it enlarges the nasal sac, because now it's added all this empty space from the vacuoles. And then it also thins out the nasal fin, because a portion of the nasal fin's been lost to the formation of the vacuoles. And so that thins out the fin, allowing it to become the oral nasal membrane, which then promptly ruptures, which creates what are called the primitive choana. I'm sorry, only half of that word is highlighted in orange, but at any rate, those are going to be part of the wall of the nasal cavity. Finally, the intermaxillary process, with which we have spent so much time, is going to form the base of the nasal sac. And so you can see it sort of moves, in the front. It looks like it's right in front of the face, and it is, but it also extends backward into the face, forming sort of the floor of the nasal sac, and ultimately the primary palate, which we'll talk about in a couple slides. Or possibly in this slide. Okay, so week 7 and 8, the nasal and oral cavities continue. We're now, okay, that's occurring out of order, I apologize. So the maxillary prominences extend medially, okay, so they're growing towards each other in the middle, okay, and they form the palatal shelves, which will ultimately separate again the nasal cavity from the oral cavity, the nose space from the mouth space. When they fuse, they will fuse with each other and with the primary palate, and that forms the secondary palate, which is the roof of your mouth. Okay, so the thing you run your tongue along the top of, you're running along the top of your mouth. You know what the roof of your mouth is. Okay. At any rate, if they don't fuse and you're left with a cleft in the palate, and we're about to talk about facial clefting, but it's worth noting because it's kind of highlighted by these pictures, that in fact the things that you eat can flow through the hole in your palate up into your nasal space, okay, which makes it difficult to eat and difficult to breathe. Okay, facial clefting, or cleft lip, cleft palate, or a combination thereof. Very, very common birth defect. Okay, and we're going to talk about it in a little bit of detail here. Okay, so there are a couple different kinds of facial clefting. There's cleft lip, okay, which is an external thing, and we'll see some pictures in a minute, but it occurs on the exterior of the face. It's the failure of the maxillary prominence and the medial nasal prominences to fuse, and we've highlighted them in the picture up above so you can see what it is that needs to fuse. Usually, cleft lip is left-sided and unilateral, but not midline. So we talked about this way back in week 1. Usually when cleft lip occurs, it occurs moving down from one nostril towards the lip, or conversely moving up from the lip towards the nostril. At any rate, that makes sense when you think about development. You think about how these structures are coming together. Okay, there's the mandibular process, intermaxillary process, is forming at the middle. Okay, and then the maxillary process is sort of coming from the side to merge with it. And if that merger fails, then you're left with a split that extends down from one nostril. Okay, and that's a classic cleft lip. Usually left-sided, can be right-sided, but it can also be bilateral or midline. So bilateral meaning that coming down from both nostrils, midline meaning that it runs straight down, so that would be a failure of the intermaxillary process rather than this fusion. And as we talked about way back in week 1, a bilateral cleft is much more likely to be associated with a syndrome and other problems than a unilateral cleft because it's rarer, less likely to happen by chance alone. And a midline cleft is much more likely than any of the one or two-sided clefts to be associated with the syndrome because, again, a midline cleft is a much more difficult process to explain in the embryo, much more likely to have an extra cause, a genetic cause. All right. So the other thing I will point out here, and we'll see it in some of these pictures in a little bit, is that if you have a bilateral cleft, there's nothing to anchor the intermaxillary process into the face, and so it does tend to flip up. They're not showing it in this picture, although we'll see somewhere it is, but it tends to sort of flip up toward the nose because it has no anchor. Okay, so that's cleft lip. Cleft palate, on the other hand, is a failure of the palatal shelves to fuse, which is a lot easier to explain. And there are varying degrees of cleft palate, depending on how much fusion occurs or does not occur. Of course, you can get cleft lip and palate together. Usually these are, pardon me, so I didn't finish out all of my cleft lip and palate discussion from the last slide. I advanced too quickly. But in the interest of not going back, there are many, many different causes of cleft lip and palate. Okay, usually they are random. They can be genetic. And the syndromes that your book talks about are van der Vood and 22q. Van der Vood is an interesting one because it's familial cleft lip and palate with lip pits, so little like dents on the insides of the lips. So when you ever get a family that's reporting a history of cleft lip and palate, it's always worth asking about lip pits. Occasionally you'll pick up a van der Vood family where the recurrence risk for a person who has the cleft for their children is 50%. It's a dominant syndrome. 22q is a microdeletion on chromosome 22, very frequently associated with cleft palate in particular, and common enough that all children with isolated cleft palate, and in some cases cleft lip, are tested for 22q. It's an easy test to do, and it certainly helps with care for those children because children with 22q are more likely to have other birth defects, including heart defects, and learning issues, and in some cases outright mental retardation / intellectual disability. Seizure medications, along with many other medications, will cause facial clefting. Maternal diabetes will do it. There are a number of environmental exposures, including alcohol. There are lots and lots of things that will cause it. It's an easy birth defect to cause. It happens randomly with some frequency, and it goes along with a lot of genetic syndromes. Okay, which brings us to ultrasound. So, can we see this by ultrasound? For cleft lip, yes, we see it a lot, but we also miss it a fair amount. It can be very, very subtle. And so what I'm showing you in this picture here, so this is 2D ultrasound, and to get you oriented, this is a view that's called the nose and lips, okay? So you want to get the nose and the lips in the same plane, meaning you can see them at the same time, and that's your best shot at finding a cleft. So the nose and the lower lip are highlighted here, and then the upper lip you can see sort of a black space, and that would be an empty space where there's no tissue, and in this baby a unilateral, so a one-sided, left-sided in this case, cleft lip. Now, with the advent of 3D technologies, it's gotten a lot easier to see them, although in reality they're still most often picked up on 2D ultrasound, and then this is actually one of the applications where 3D ultrasound really has a lot of medical benefit. For many things, 3D ultrasound does not provide a lot above and beyond what you can get with 2D ultrasound. But for facial issues and cleft lip in particular, it does. Now, cleft palate is a lot harder to find by ultrasound, and a lot of time when we find clefts like this that are not huge clefts, it's hard to tell. We don't know if the palate's also involved. Isolated cleft palate is almost never found before birth. So this is something we can find by ultrasound and do with some frequency, but certainly not all the time. Okay. And I should say, before I move on from ultrasound, getting these images really depends on a cooperative baby. So if you, as you can imagine, if you don't have a lot of fluid in front of the face, you won't get these pictures. You need that fluid for the sound waves to travel through. And if you get a kid that's real intent on sucking his or her thumb or putting their hands in front of their face or their feet in front of their face, you will miss this. It's just you need the right view to see it, and if the baby doesn't give it, you're not going to see it. Okay, so repairs. I'm not going to go into all the details for how they fix cleft lip and palate, but it's worth looking at the repairs because the repairs are good. They're getting better and better and better. And this, from a cosmetic perspective, is a very correctable issue. I think the scary part for families a lot of times is that because there are so many other things that can, although usually don't, go along with it, when you know in advance that you're having a baby with a facial cleft, there's always a certain amount of anxiety about whether or not there's something else going on. But from a purely cleft perspective, the repairs are really, really good. All right, so we're going to look at some pictures of that. So the first one, this is a relatively mild unilateral cleft. Mild because it doesn't actually extend all the way up to the nostril, okay, which makes it a lot easier to create a good cosmetic repair because then you don't have to fix the nose as well. Once you fix the lip, that sort of pulls it into place. And you can see this little kiddo is looking very pleased with his or her cleft repair, I presume. So this is a somewhat more classic cleft in that it extends all the way up to the nostril, almost certainly includes the palate. This one happens to be right-sided, although they are usually left-sided, and again, the repair is very, very good. The bilateral cleft, so you can kind of see it with this one, although if you get on the internet and you look up cleft lip and palate, you'll see lots of different pictures of these. You can see that sort of middle band of skin and muscle and tissue sort of in between the two clefts. That can actually sort of flip upward towards the nose, which is something you can see by ultrasound. But again, even with the bilateral cleft, the repair is very good. And I think for all three of these children, unless you knew what to look for, you probably wouldn't notice the repair. And in some cases, I think there are some children where even if you know what to look for, you might miss it. And so the last category of cleft repair I'm going to highlight is Joaquin Phoenix, who is, I think, the most famous example I know of a famous person with a cleft repair, who has been very successful in his career and in an industry that is, I think as everybody knows and understands, very focused on physical appearance. And yet he has done very well, and his repair, of course, was done a long time ago. I believe he was born in 1974, so it would have been repaired in the 70s, and even at that time the repairs were good. So I just thought I'd point out that of all the birth defects we've talked about and some of the things that we've gone over and how difficult they can be to fix, or in some cases impossible to fix, this one is fixable. And when we see families and counsel them about a prenatal diagnosis of cleft, well, of course, we do talk about the uncertainty about surrounding the possibility of an underlying syndrome and other problems. We also focus a great deal on how this is something we can fix, not us personally, but other people can, and that the quality of life can be really, really good for isolated cleft lip and palate. And we show them pictures like this. I get on the internet, I find pictures of repairs, and I show them because people don't really get how good it can be.